Everybody. Good evening, everybody. Welcome to American Association of Plastic Surgery webinar series. Thank you, AAPS, Dr. Gossain, our president, for this invitation and setting up this webinar. Tonight's topic is going to be surgical treatment for refractory migraine headache. Our panelists are very well known. Dr. Gairan is the past president of AAPS. He's the father of migraine surgery. This year is the 25th year, almost quarter century ago, is that migraine surgery was discovered by him. And he's going to be talking about frontal trigger points, occipital trigger points. The second panelist is going to be Dr. Ansari. He's a neurologist in UCSD, San Diego. He's associate professor over there. He will be talking about the peripheral mechanisms of the migraine headache. And at the end, I will be continuing the talks with rhinogenic trigger points, auriculotemporal, and zygomaticotemporal trigger points in the temporal area. At the end, we are going to have a question and answer series, and we will try to answer your questions as best as possible. Dr. Ansari, do you want to go ahead and start, please?
Yes. Thank you very much. And can you hear me well?
Yes, thank you.
Perfect. Thank you, ASPS and Dr. Gossain, for inviting me to talk in this webinar today. And my talk will be more introduction to the migraine, of course, and also focus on the peripheral mechanism of migraine, which can explain why we think surgery could help in some of the patients. And also, since the title of this webinar is the treatment option for chronic refractory migraine, I will show you some slide about what is even refractory migraine means. My disclosure has nothing to do for today's talk. And first, let's look at the International Headache Society classification about the headache in general. As you see in this algorithm, we have the two main category of headache, which is the primary headache disorder and secondary headache disorder, which our focus is mainly the migraine, which is the most known primary headache syndrome, and we will talk about that. So let's see what is migraine even, because a lot of time we see that the people use the term migraine and headache interchangeably, which that's not true, because migraine is the complex neurological disease, and the headache is hallmark of that neurological disease. But that doesn't mean that any severe headache is more migraine or vice versa. And also, it doesn't mean that all of the patients with migraine have headache. We have the patient with migraine who do not get any headache and just experience other component of the migraine. As you see, each migraine basically complex can have 4 phases. The prodromal phase, which could be even a day or two before migraine, and the people experience mood change, stiff neck, and all of those symptoms. Then about 1/3 of the patient with migraine, they will experience aura, which could be visual, sensory, motor, speech aura. And the headache phase of the migraine, which is the well-known or hallmark of the migraine, has its own criteria. The headache of migraine has a throbbing quality. The patient should have nausea, vomiting, or light and noise sensitivity, and also headache get worse with any sort of physical activity. And then some people experience post-drome phase of migraine or resolution, which might take a day or two, and patient feel drained and washed out and very tired. So, but as I mentioned, some patients with migraine even don't have headache. They only have aura or prodrome. Those are the cases that we used to call acephalic migraine. So we need to know the difference between migraine and headache, and that is one note here. The epidemiology of migraine is extremely common, 1 million people worldwide, so 1 out of 5 women. So if you go to your waiting room and you have 10 patients sitting, 2 of them should have migraine at least, so a female. And in men is a little less common. So now let's talk about refractory migraine. So as you show in the algorithm in the International Headache Society, we even do not have any definition for refractory migraine. And so that's still, it's questionable what we should call refractory migraine. we usually define the refractoriness of the migraine based on the chronicity, frequency, and severity. But again, all of these is depending on who is basically defining it, because we don't have any classification. There's no criteria for refractory migraine. And that's why the definition of this refractory migraine has been the subject of great deal of interest. And so this is basically the most recent article on refractory migraine from this year, 2024, and which actually by some of the very well-known headache specialists, including Dr. Sacco from Italy, which they talk about the refractory migraine, and they basically put in this article that the small but yet undefined proportion of individual with migraine experience disabling attack that acute and preventive strategies fail to control. So they call those patients refractory when they fail abortive and preventive treatment. And then treatment failure defined either as a lack of efficacy after trying a drug with the appropriate dose for enough duration, or intolerance, or contraindication. So these are the basically definition of the treatment failure. And for those patients, they categorize as a refractory headache. But as I mentioned, until we do not have any clear criteria, we won't be able to define very well. So there's a lot of different articles talk about the refractory migraine throughout the year. So these are the articles from 2006 up until recent, and probably the best one that I use, because this European Headache Federation, as you see in the right-hand corner here, they have a definition for resistant versus refractory migraine. And in the resistant migraine, they are actually talking about debilitating headache for more than 8 days per month for at least 3 months, and patient had contraindication or failure to 3 preventive medication class. And the refractory migraine, again, the same disabling headache, but more than 6 months rather than 6 months, and also contraindication or failure for all preventive classes. So this is the best, at least this is something that the European Headache Federation defined, and if we want to do any research or anything, probably this will be the best definition for the refractory migraine. What I would like to basically classify is difficult to treat migraine, which means we use 1 or 2 medication, doesn't respond. Then resistant migraine, and I agree with the EHF, failure to at least 3 treatment, and then we have a refractory migraine, which, as you see here, there's definitely some overlap between refractory migraine and resistant migraine here. So this is basically progression of the difficult to treat all the way to the refractory migraine, which today talk and surgical talk will be in those refractory patients. So we have to we need to know that the refractory or even resistant migraine is rare in general population, but it's not rare at all, and in fact frequent in the headache centers. So the patient that at least I see in the headache clinic, almost all of them either have one of these 3 for sure. We don't see any patient beside this type of the migraine patient, either difficult to treat, resistant, or refractory migraine. And treatment related, an individual factor also might cause any individual with migraine to be resistant. So that's why we need to look at the other factor that can make the migraine refractory and resistant, and remove those, particularly the psychiatric condition, which is the major comorbidity for migraine. And before we label and go for any procedure, we have to make sure patient doesn't have the major psychiatric comorbidity that cause the refractory migraine. So now let's talk about the pathophysiology of migraine, which is, it's a complex condition. And even after these many years, we still have a big debate about the pathophysiology of migraine, particularly generator of migraine, where the migraine start from. We know that trigeminal nerve activation and the release of some of the inflammatory neuropeptide particularly neuropeptide that called CGRP or calcitonin gene-related peptide, is the key player in the pathophysiology of migraine. But there is still debate why even that CGRP release from the trigeminal nerve and what is causing that release. And so that is still debate. We know there is a prominent genetic component, but even the people who has this genetic component, the underlying cause that why this migraine start or where this migraine start particularly is still debate. The only part of the migraine that is well defined is the aura, which the phenomena we call cortical spreading depression start in the cortex. That is basically abnormal wave from the cortex which cause the aura. That part is the only part of the migraine that well defined. But the pain part of the migraine or headache part of the migraine still debatable, and I'm going to show you some of the slide in this regard. This is again the complex pathophysiology of migraine. As you see, there's a lot of neuropeptide and receptor are involved, but the CGRP is the key player, at least we know. The next neuropeptide, which is under investigation now, and probably in the next few years, we will have a medication to work on that neuropeptide called PACAP, pituitary adenyl cyclase activating peptide, which there is a lot of drug company working to develop medication in that. But currently we have medication, a lot of medication that works on CGRP. And it is interesting to know that medication, the monoclonal antibody that we are using for the treatment of the migraine and work on the CGRP does not basically pass the blood-brain barrier. So they works peripherally, and that is one of the key point regarding the pathophysiology of migraine and why we think the migraine pain at least start outside of the brain in the periphery. Even trigeminal ganglion as a key component, basically anatomic component of the migraine pathophysiology is outside of the blood-brain barrier. So that's why we think this headache phase of the migraine, which is the hallmark of the migraine, most likely start peripherally. This is something that the people strongly will disagree with it, and still maybe half and half, basically, between neurologists agree and disagree. But until 2009, when this very nice paper published in Lancet Neurology, but by three of the giant in the headache medicine, Dr. Olesen, Bernstein, and Dr. Ashina, and that is the first strong article that talk about the peripheral mechanism of the migraine. And in this article, they told that there's a little or no evidence to show that with certainty which pain fibers activate and what activate them during the migraine. And then they actually put the most investigator currently believe that the migraine attack start in the brain, as is suggested by the premonitory symptom. However, there is an ongoing debate that argue against this, and some people, including us, that means these three main headache specialists, believe that the headache phase begin with the activation of the peripheral nociceptor. And after this article, the neurologists started to looking and become a little more open-minded about the peripheral pathophysiology of the migraine, and particularly headache phase of the migraine. So we have long way in the pathophysiology of migraine. So probably you remember when we were in the medical school, they were talking about the vascular theory for migraine, which until 1900s, that was the main theory for the migraine pathophysiology. They used to call vascular migraine because it's caused because of the vasoconstriction and all of those. But those theory went completely, we know that's not true. And now we think the migraine, which is the complex neurological disease, is mediated through the trigeminal system, which is outside of the brain. And the headache phase of migraine attack correspond to the development of the peripheral sensitization involving the primary afferent that go to the trigeminal ganglion, as you see in this slide. So what is next? Is it central or peripheral? As I mentioned, still this is under a debate, but we know that both central and peripheral component in the migraine can have basically some role. There's a lot of basically things that can support the peripheral mechanism. For example, injection of the Botox, which we do, and also anti-CGRP monoclonal antibody as a main treatment of migraine, at least in the last 5-6 years. Those don't pass the blood-brain barrier. They works in the periphery, and that tells us that pain part of the migraine is most likely is a peripheral phenomena rather than a central phenomena. There is a lot of other evidence that suggests the peripheral mechanism. As I mentioned, the Botox is one of them, but the one that is very clearly tells us that the peripheral mechanism is very important is the nerve block. So we do the local anesthetic nerve block either in the occipital branches or trigeminal branches in all of the migraine patients. This is one of the tools that almost all of the headache specialists and some of the neurologists use as a part or as a tool of their treatment. So patient come with a severe headache, we do nerve block, gets better. And this clearly tells us that the peripheral mechanism is strong, at least in the pain part or headache phase of the migraine. And again, there's a lot of other articles, very good article that published in the last few years. And one of the best one is the article from Journal of the Headache and Pain from the Danish group. They actually discussed and they clearly put that the both peripheral and central mechanism likely involved in a migraine attack, and that peripheral nociceptor input is necessary for pain transmission and cortical activity is necessary for pain perception. So we have the basically transmission of the pain and perception, and that transmission start in the periphery. But still a lot of discussion going on in this, and there's a lot of debate. But what is not debatable from my point of view is migraine-specific preventive treatment, CGRP, does not pass the blood-brain barrier. So most likely works peripherally, and that's why pathophysiology of pain or headache phase of migraine is in the peripheral. This is, to me, is not debatable, but there is still debate. This is actually debate from the last American Headache Society annual meeting a few months ago here in San Diego, when there is two main giant physician from the field of headache, Dr. Goldsby in the right-hand side, immediate past president of International Headache Society, and Dr. Rami Bernstein, who is the current president of International Headache Society. They debate about the central versus peripheral. Dr. Goldsby was central, Dr. Bernstein was peripheral, and that was quite a battle over there, probably not as intense as presidential debate, but was very close. And so this tells us that there is a still debate is ongoing, when in 2024 we still have this debate going on between two giant headache neurologists. Of course, that tells us that there is debate. But as I put in my slide, from my point of view, that pain phase of the migraine is most likely peripheral because of all of the reason that I show in this slide. Thank you very much, and hopefully in panel discussion we can answer some of the questions.
Thank you, Dr. Ansari. So Dr. Gairan is going to continue the surgical treatment. We're going to shift the gears a little bit. He's going to start with frontal trigger points and occipital trigger points. Dr. Gairan, please.
Well, I want to extend my share of thanks to Dr. Gossain for reinitiating the webinars, and it is an integral part of education mission of the AAPS and allowing us to share some information about migraine headaches, which has been an enormous part of my practice now. These are my disclosures, and I'm not going to say anything that would have any commercial aspect to it.
Dr. Geyer, I'm sorry to interrupt. Your camera is cutting off your face. If you don't mind just adjusting.
Camera is cutting a what?
Your face is is cut off by camera. It's not in the center. Yeah, thank you.
How is it now?
It's great. Thank you.
Okay. So, are you still seeing the slides? Okay.
Yes, we can.
So Dr. Ansari talked about peripheral mechanism being debatable. And he also expressed his own feelings that he believes that there's a role to it. I have absolutely no question about it. In fact, in the beginning of our discovery of migraine headaches, I was convinced that there's absolutely no question that there's a role to the peripheral mechanism. And what I'd like to do in this presentation, talk about detection of the trigger sites, because if it starts from the periphery, we need to find where it starts from, which nerve is involved. And I'm going to talk about the surgical treatment of frontal and occipital headaches, and talk about the evolution of how much we are doing the surgeries under local anesthesia as an outpatient operation, and the patients go back to work the next day or even the same day without any limitations, obviously in a properly selected cases. So the other thing that I want to actually start with is talk about the evidence for efficacy. For those of you who are not familiar with the studies that have been done, just our center alone has done many other studies. And we started with a retrospective study, then prospective pilot, prospective randomized with sham surgery, 5-year follow-up. So to prove that actually not only the surgery works, the results last. And our center alone has published 44 articles, but over the years, many other centers have they're actually demonstrated that our results can be matched by their surgeries, and it has culminated to over 100 surgeries over the last almost quarter of century, as Ali mentioned. In fact, there are 3 books written about migraine surgery, and we also have a migraine surgery society. And those of you who are interested in joining us, please go to the website, and we'll be happy to sponsor you to be part of the society. So the migraine headache treatments, starts with a diagnosis of headaches made by a neurologist. As a plastic surgeons, we are not really qualified to make the diagnosis of migraine headaches. So we have discovered that the most common reason that for some patients, the results are not as gratifying as we expect, and those that fail are the consequence of not being able to detect all of the trigger sites. So detection of the migraine trigger site is an integral part of success of migraine surgery. So to do so, my patients that call my office for an appointment, they are offered a log of headaches. And this log will include the recording of the signs and symptoms for a month prior to their visit to the office. So when I look at this list, I know exactly what the patient's problems is and where they are starting from. It records frequency, severity, duration, trigger site points, where they start from, associated symptoms, and many other relevant pieces of information. And I'm happy to share those forms with you. All you need to do is send me an email to bgayuran@gayuran.com. My first name, initial, last name, and lastname.com. At lastname.com. So in order to find the trigger site, so we look at these constellation of symptoms, ask the patients where the headaches start from. And if the patient has headache at the time, we're going to do a nerve block. I'm going to discuss these in details in a minute. And ultrasound Doppler has been an enormous portion of my practice. And CT, if the headache start from behind the eyes. And Ali will discuss that with you and show you what is that we find in the CTs. The reason that trigger site detection is important, according to this very extensive study that we did, each patient has approximately 2.5 trigger sites. And we need to detect those. Obviously, there are patients who have only one trigger site. There are patients who have 5, 6 trigger sites. But those are the rarities. Most patients have 2, 2.5, 3 trigger sites in average. And these are the sites where the headaches can start from, and we're going to cover most of these. The first question that I asked of the patient when I see the patient is, where do your most of your intense and frequent migraine headaches start from? And this question is absolutely crucial. And it's important also to pin down the patients, because in the beginning, they're going to be pretty vague. Some of them, they just walk to the office and point to the spot, say, my headaches start from here with the index finger. And I would ask the patient to point to the spot with the index finger. They're going to use their palm of the hand. That's not good enough. I ask them to just find the most tender spot. I can assure that almost every patient is going to be able to do that. And the reason that that's important, and for example, there's the temporal headaches that Ali is going to talk about, can start from the hair-bearing skin or non-hair-bearing skin. And those are two different headaches sites. And if the patient has more than one trigger site, I want to make sure that they are independent trigger site. And the way I do it is ask them that question. Well, do you have any other headache trigger site after I identify the first one? And if they say yes, I'm going to say, okay, can you have headache? Show me where it is. And after the patient shows me, I ask them, can you have headaches there without having headaches on the other side? And then that's going to, if the answer is yes, that's an independent trigger site. And I'm going to also use the ultrasound Doppler. As I mentioned earlier, this is an integral instrument for my office. And listen to this video, please.
Perfect. Just keep it there. Let it go.
And when you use this ultrasound in almost 100% of the patients who have been able to find this spot, you're going to find a vessel signal. And when I, down the road, emphasize the importance of removal on vessel, you will see the reason why. The role of nerve block is absolutely important if the patient has headaches at the time of examination and the response is positive, meaning if I inject half a cc of naropin or lidocaine in the spot where the patient is pointing to and headaches go away, that is wonderful. That's very helpful. But if it doesn't If the patient doesn't have pain at the time of surgery, obviously it's not going to be helpful. Or if the patient's headache doesn't go away, doesn't mean that the patient is not going to have benefit from the surgery. So a negative nerve block doesn't mean that the surgery is not going to help. A positive one is almost good news for essentially every patient. That's why I don't really pay attention to a negative nerve block so much. And as I mentioned, a CT of the peripheral sinuses, CT of the peripheral sinuses is extremely important. And Ali is going to show you why, especially on patients who have peripheral headache, headaches behind the eyes, or patients who have frontal headaches. On the frontal headaches, I can actually see whether there's a foramen or not, or whether there is an accessory nerve or not. So with this just to summarize, with a combination of a neurological examination by the neurologist, 1 month diary or log of the headaches, patient point to the site, proving and identifying independent trigger site, nerve block, Doppler signal, and also CT if it is necessary. I'm going to find essentially the trigger site for over 90% of the patients. There are patients that are difficult or vague, or they don't really help you that much, but that is really rarity. So I'm going to talk about 2 headache sites. One is the frontal headache site where the pain actually starts from the supraorbital area. The patients have strong frowning muscles. I'll show you an example of that in a minute. And there's severe tenderness in the supraorbital and supratrochlear side. And these patients respond very favorably to injection of Botox. If they don't respond to the Botox, doesn't mean that they're not going to have surgery. And again, CT of the perinasal sinuses may reveal presence of supraorbital foramen or accessory nerve. Here, the headaches start from the irritation of supraorbital supratrochlear nerve by the adjacent vessels and muscles. And here you can see actually foramen, that this is a perinasal sinus CT. You can see a foramen on one side and accessory nerve on the other side. That's why the CAT scan becomes helpful. How do we treat these surgically? If the patient has isolated frontal migraine headaches, bilateral, again, bilateral headaches, I'm going to use transpalpebral approach. This is a technique that I developed in 1993 for cosmetic reasons. That's exactly the same operation with some modification for elimination of trigger site as well. And it can be done under local anesthesia with sedation, or almost invariably I do it under general. Take a look at the muscle function on this patient who's frowning, and we're going to operate on this patient. And I'm going to mark the supratarsal crease on a sitting position, and in a lying down position under anesthesia, general anesthesia, I'm going to inject the eyelid profusely with xylocaine containing 1 in 100,000 epinephrine using that 1-inch 30-gauge needle. I'm going to also inject the supraorbital area and glabellar region, again diffusely with the same injection. We're going to make the incision through the skin and go through the orbicularis muscle, but not under it. We're not through it. We're going to detract those and dissect the muscles. Actually, let me go back to this one more time. So as I go through the muscle, I'm going to retract the muscle and use the baby medicine balm to carefully dissect under the muscle deep. Initially, starting with the cautery, then using the baby medicine balm, as I mentioned. And I want to get under the muscle above the orbital septum. I will continue the dissection. That's the orbicularis anteriorly, and I'm elevating the depressor superciliary muscle. It is a thin muscle and may or may not exist on every patient. But then I'm going to get to this muscle, which is the corrugated muscle. And you can actually see the orbicularis right there, that this is actually part of the depressor superciliary. We're going to remove that, then we're going to get down to underlying muscle, which is going to be corrugated muscle. And invariably, immediately, there's a good sized branch of the supraorbital nerve that I'm going to preserve. In fact, I'm going to dissect along the vessel deep, remove the vessel, and remove the muscle, remove the vessels, any vessel that I see down to the bone. And that is an integral part of the activation of this trigger site. And the muscle is, as you can see, the nerve is protected. The muscle is friable and dark, meaning the corrugated muscle, while depressor supercilia and orbicularis are lighter. And we're going to continue removing these muscle, medial to the nerve right there, lateral to the nerve, until we get down to the periosteum. I'm even removing a portion of the procerus muscle, as you see right there. And as we think that we have removed the muscle completely, we're going to find some more muscle laterally that we're going to be removing. And I want to preserve the nerves. As you can see, that's the supratrochlear. We're going to see the supraorbital in a minute. This is a supraorbital. There's a vessel right next to it. I'm going to ligate, cauterize that nerve with a bipolar cautery and remove. Now I'm doing a fasciotomy of the supraorbital nerve on this side. You see, I should be able to advance my hemostat there very easily. And here we are seeing the nerve and vessel right next to it. And we're going to remove that vessel, cauterize it and transect it. And again, do a supraorbital foraminotomy on this side. And you can see that I'm protecting the soft tissues. This is the foramen, and I'm going to use the osteotome. You can use a rongeur to do this osteotomy and remove. And you will see in a minute how the nerve is constricted within that space. That isn't always the case now, meaning that we may not see that constriction. I'm going to inject the patient's own fat that has been processed using the Coleman technique, aspirated from the abdomen. I'm injecting in the muscle and the periosteum. Usually 1 cc of fat is injected in combination of the upper eyelid, glabellar area, to make the area smoother. And as you know, fat contains the stem cells that is going to repair the nerve, as reduce the potential for neuroma. Then the skin is repaired using 6-0 subcuticular closure. Running is the fast surgery. If the patient has combined frontal and temporal migraine headaches, I may use the endoscopic approach that you all are familiar with. For lateral incisions are made. I'm going down to the deep temporal fascia and place these retracted the endoscopic access devices in position and inserted in position to keep the wound open and isolate the hair from the and facilitate insertion of the equipment as you see. A little bit of blind dissection, and this, again, supra deep temporal fascia. I'm going to say above the deep temporal fascia, but deep to the intermediate fascia. We are seeing the intermediate fascia. I'm going to get under this fat. It is absolutely crucial to get under that fat. And this is the sentinel nerve. But I'm going to mainly focus on removal of, and I'm going releasing the arcus marginalis. Then we're going to remove the corrugated muscle as thoroughly as possible, as we did through the open technique. You can see the orbicularis muscle is being removed, and I'm going to remove it again completely until I get to the subcutaneous plane. Then I'm going to replace the removed muscle with injected fat, as you see right there. And this will help the patients to eliminate the lines and have elimination of the headaches. Now, on rare patients who have, actually is becoming more and more unilateral migraine headaches, and the patient can point to the pain site, and I can detect a trigger site, I'm going to actually do the surgery through an eyebrow incision under local anesthesia. And here the goal is to remove the vessels surrounding the nerve and no muscle removal on these patients. Because if I remove the muscle on one side, the patient is going to have asymmetric function of the corrugator. Occipital migraine headaches are done on patients who have upper neck cervical headaches. Stress is a huge factor. These are patients who have headaches after heavy exercises, and they exhibit significant muscle tightness, and there's a trigger site tenderness where the nerve exits from the semispinatus capitis muscle. Here, the offended nerve is the semispinatus capitis muscle. The nerve passes through, and the nerve is the greater occipital nerve passing through the muscle that is called semispinatus, which is very thick, long muscle. And I don't think we need to focus on that. If the patient is marked in a sitting position, I'm marking the midline. That's not the incision. The dotted line is not the incision. That's the cervical spine. And a solid line is where the incision is going to be made. We'll shave a small amount of hair. The anesthesia is induced under anesthesia induced, and the patient is turned on the prone position with the head flexed over a foam, and the shoulders are going to be retracted using this tape that you see. I'm going to inject that marked area with xylocaine containing 1 in 100,000 epinephrine. Incision is made. The skin will be retracted. The incision is going to be deepened down to the midline raphe, and it starts on one side, going to slight laterally, and we'll place these retractors, self-retainer retractors in position and deepen the dissection. Now we're going to go through the trapezius muscle, leaving approximately 1.5 centimeter of midline raphe intact. And as we go through the deep portion of the muscle, this fascia, we're going to sometimes see the muscle reaching the midline. Most of the time, we don't see it in the midline. So as we go through the trapezius fascia, we're going to see the longitudinal or cephalocaudal oriented fibers of the semispinatus capitis muscle in differentiation from the trapezius muscle, where the fibers are oblique. So if I see oblique fibers, I'm going to cut through those to get to the semispinatus capitis muscle. retractors in position, the skin hooks, now lifting the trapezius fascia, and if the muscle gets to the midline, will be retracted. I'm going to use a long pair of maybe baby Metzenbaum scissors, and dissect along the course of the nerve that usually is lateral. And you can see that I'm identifying the nerve, and pretty soon we're going to, there's a tiny vessel that I saw right next to the nerve. I use the bipolar to find the nerve, and we're going to pass a Manion retractor, Manion clamp under it, and then pass and you can see the nerve, and it's a very large nerve. You really cannot miss this nerve. If you miss it, if you can't find it, it means that you're too superficial. You are above the trapezius fascia, above the muscle, and you should be deep enough to trapezius muscle. Now I'm isolating the muscle from the midline raphe before I do anything with it. Next, we're going to put the retractors deeper now you're seeing the semispinalis, you've seen the nerve right there. And we will use, again, a pair of Manion retractors and follow the nerve deeper, because I want to get to the deepest portion of the semispinalis capitis muscle before I remove a portion of it. And again, using these retractors, cryo retractors may help to visualize the muscle better. Now we're going to start transecting the muscle to get down to this fibro-areolar tissue, and then reflect the muscle cephalically. And I'm now exploring the exit point of the nerve to make sure that there's no compression there. And the clamp is placed in position. I'm going to free up the muscle a little bit more and remove approximately 2 centimeter by 1 centimeter of the muscle to make sure there are no muscle fibers left medial to the nerve. Now I'm dissecting the nerve, and there's a tiny branch going to the trapezius muscle coming superficially. I'm going to transect that. Any vessels along the nerve are going to be transected. Now, at this point, I'm removing a triangular piece of trapezius muscle and the fascia. That's because the muscle at this point extending to the midline. Even if there's no muscle, I'm going to remove the fascia to expose more of the nerve. And then we will do a procedure like carpal tunnel, meaning release the fascia until we get to the subcutaneous plane. This dissection will be continued until I see some vessels. Almost invariably, you're going to find some vessels either passing through the nerve or entangled with the nerve. I'll remove all of those and free up the nerve completely, inject tiny amount of Kenalog around the site of the nerve in the subcutaneous plane, then raise a subcutaneous flap of fatty tissues. And we're going to pass this under the nerve and work on the other side. And if I see the third occipital nerve, which is a small nerve like this and is small, I'm going to transect it. If it is large, I'm going to implant it in the muscle. But that is unlikely. Now we have found the other nerve, and we'll do exactly the same thing on the other side. Now we're going to approximate these flaps under the nerve to the midline raphe as deep as possible, to avoid retraction of the flaps as they are healing. So the nerve is always isolated from the muscle. Irrigate the wound and repair it in details, eliminating the dead space, approximating subcutaneous skin to the muscle, and skin is repaired. The superficial layer is a big 5/0 plain catgut. On rare cases that I have unilateral greater occipital headache trigger side, and the patient can point to it, I'm going to Doppler it and do a nerve block if the patient has pain at the time, and if that's risk, and if I can be sure that this is where we should be operating on, which almost invariably do, then I'm going to remove the vessels and free up the fascia around the nerve and no muscle removal. And the last site that I want to talk about fast is the site 6, which is the lesser occipital. And I'm going to Doppler the area. Then inject it with lidocaine, make an incision, find the nerve, and this nerve is sitting between the sternocleidomastoid muscle and the semispinalis capitis, or the other muscles, and it's lateral to the, usually lateral to the sternocleidomastoid muscle. And I'm going to find the nerve, isolate it, and remove any vessels around it, as you saw there, transect the nerve and bury it in the muscle. I'm creating a pocket. We're going to pass a suture and pass the suture, retrieve it internally. Let me just show that again. Passing the suture, passing through the nerve. It is out in, suture passed out in. Now we're going to pass it in out. And as we pull it, it is going to retrieve the buried nerve in the muscle, then inject tiny amount of canalog area in the area, repair the muscle. And that will be the end of this. In summary, I've shared my way of detecting the trigger site, the surgical treatment of frontal and occipital headaches, and indication where we use local anesthesia. Thank you very much for your attention.
Thank you,
Adele.
Dr. Gaira.
Okay, now you can go ahead.
So attendees, please go ahead and type down your questions if you have any questions. So in the question and answer part, we can go through them. Thank you, everybody, for staying around. I'll try to not to repeat some of the topics that has been mentioned. I'm going to be talking about the temporal trigger points, zygomaticotemporal one, which is called trigger point number 2, nasal, which is trigger point number 3, and 5 is auriculotemporal. 2 and 5s are in temporal area, and 4 and 6 is in the occipital area, as Dr. Gairan mentioned. I will start with the rhinogenic trigger point. The studies about nose being the source of headache goes back to early 1900s. In 1943, they were able to stimulate the various parts of the nasal cavity and basically cause headache. Later on, they detected that in the nasal cavity, ostium is more sensitive than sinuses, and turbinates are more sensitive than septum itself. One of my most favorite articles in this topic is in 1980 in Morgenstein and Krigler. They described a syndrome called middle turbinate syndrome. This syndrome, they mentioned that has a pain and obstruction. Pain, they said it's because of the septoturbinal compression, basically contact point, or concha bullosa. Obstruction was because of the septal deviation or without septal deviation. They described the four-finger headache symptom, as you see in the right side, the lady holding the nose with 4 fingers during the pain. And they had 36 patients 18 of them, they had headache, and 17 had obstruction, and 2 of them, they had both. And they did surgeries, including septal surgery and turbinate surgery, and literally out of 19 patients, 17 of them that responded pretty well. Later on, another study was done in Brazil in 1996. Basically, they had the same success rate, around 80–90%. And again, it was with septoplasty and turbinate surgery. In 2005, Dr. Gairan's comprehensive surgical treatment of migraine headache included migraine number 3, which is a rhinogenic trigger point, which was included in this article as well with a good success rate. After that, studies from Taiwan. The good thing about the Taiwan study was that they excluded of the sinusitis-related rhinogenic headache, and they focused only on the contact point, and they had about 81.8% success rate after surgery. South Korea, this is not a surgical study, but this is a great study because of the large cohort that they had. They included 9,175 patients in the septal deviation group and almost to 29,000 in the control group, which they didn't have septal deviation. And they calculated a cumulative hazard ratio. They basically, over 10 years, they noted that the people who have septal deviation, they're in the higher chance of getting headache over the time. Again, I had much more articles on this, but I summarized them due to the time. All of these articles, they call this different names. They called it sinus headache, they call it middle turbinate syndrome, migraine headache, sphenopalatine ganglion neuralgia, sinonasal headache, contact headache, or rhinogenic migraine. And if you see the International Headache Society classification, as Dr. Ansari mentioned, it is lacking these classifications for the nose. In the IHS classification, the only thing that is related to the nose, it says headache due to the acute or chronic rhinosinusitis, which I think needs to be upgraded. The nose being the source of headache, although has tons of articles about it, has some skepticisms as well. Interestingly, not much from the neurology colleagues, most of them from ENT colleagues. And I went through lots of the articles against the nose being the source of headache. And most of them, they literally selected the patients who had a septal deviation or contact point. They operated on them without making the detection of the nose being the trigger point. Most probably some of those patients, they had frontal trigger point, temporal trigger point. Only thing they asked the patient was that if you have headache. Basically, they were lacking that identification of the trigger points, which is a big issue, in my opinion. We don't have to go over the anatomy of the nose. Everybody is well aware of the anatomy of this the turbinates and septum. But the one thing that is important is that very rich nervous supply to the nose, which all of these nerves that supply the septum and mucosa of the turbinates, they go to sphenopalatine ganglion. Literally all of them, they go to that area, which is a part of V2. And SPG block could be useful in the detection of this trigger point as well. What is the theory behind rhinogenic trigger point? Is the irritation of the mucosa can initiate the cascade of events that can cause headache in these patients. Pathologies that we see is a septal related, like septal deviation, spur, turbinate related, like concha bullosa, paradoxical curve, which shows periodic contact point, and turbinate hypertrophy or sinus related. We detect these trigger points based on the constellation of symptoms, mucosal edema control, which can be done with the afferent test or head elevation, block of the nose with either lidocaine or afferent test or SPG block, and CT scan is very clear on these patients. Nasal endoscopy is also useful. Constellation of the symptoms, pain is usually behind the eye. These patients wake up in the morning with a headache or wake up in the middle of the night. It's triggered by the weather changes, rhinorrhea is possible, hormonal changes, menstrual cycle also triggers the nasal trigger point as well. CT scan, we usually look for some type of contact point between the septum and turbinate. This is the same patient. the spur is so big that it starts anteriorly contacting to the middle inferior turbinate in the right side and goes all the way to the posterior turbinate in the same side, basically. It was that big of a turbinate. And this patient had a great response to surgery. This patient has a contact point between the septum and the nasal wall, contact point between the septum and the middle turbinate. Concha bullosa also is one of the findings in the CT scan, and this patient also has a contact point between septum and inferior turbinate. Haller cell, personally, I didn't have I don't have experience with treating Haller cell for the migraine, but it's been mentioned in some of the articles. And this patient basically has everything: concha bullosa, deviation, contact point. Basically, this patient has everything, every pathology possible in the nose. In the study that Dr. Gairan did, nose was one of the most common trigger points in the migraine headache, was #1 in the study that was published. And the most common pathologies were septal deviation and contact points. And third one was a concha bullosa. Personally, I like to do afferent tests if I have any question between this trigger point or other one. I usually ask the patient to do spray of afferent to during the first 10-15 minutes of the headache, when it's going to start, into the nasal cavity, and see if it is going to eliminate the headache or stop this cascade of the pain. Nasal endoscopy is also
This is a right nostril nasal endoscopy, shows the nasal spool poking into the inferior turbinate, and in view we can see the contact point between middle turbinate and the septum.
And the goal is to turn a patient with this contact point, concha bullosa, to the patient like this without eliminating mucosa or causing dryness of the nose or empty nose syndrome. Surgical treatment is based on pathology. If there's a septal deviation, septoplasty, turbinate hypertrophy, needs a turbinate reduction. And my preferred technique is to do with the endoscopic assisted. For inferior turbinate, we can do odd fracture, but again, submucous resection sometimes is needed as the bony part of the inferior turbinate is too big. Odd fracture has a limited use. The direct excision or reduction of the inferior turbinate is almost historic. We don't use them anymore because it affects and scars down the mucosa a lot. Middle turbinate is usually done with the scope. Direct approach is also possible using a rongeur to remove the inferior turbinate. I try to shave the contact area using a scope. Usually uses 0-degree camera with a Medtronic shaver. And this is the use set that I use. The top one in the right side over here is the middle turbinate one, and this is for the inferior turbinate one that I use. I'm going to go over the video that goes over the treatment.
In this video, we will go over septoplasty and turbinate reduction for migraine surgery. Nasal endoscopy shows nasal spur on the right side, turbinate hypertrophy, again, nasal spur and hypertrophy of the turbinates on the left side. After injection, we design modified Killian approach mucopericardial incision. Incision is made with a 15 blade, and mucopericardium is separated from cartilage on the left side. Then L-strut is designed using a sharp end of Freer. Cartilage is cut and dissection is carried on the right side of the submucopericardial plane. After separation of the cartilage from attachment to the mucopericardium, sharp end of Freer, cartilage is separated from vomer bone and also maxillary crest. Sometimes the caudal part of the cartilage is dislocated over the maxillary crest, and care needs to be taken not to perforate the mucosa. Then nasal spur and the bony part of the septal deviations, carefully separated from the mucopericardium and is removed, as you see in the video, using double action run short. Then mucosa is repaired with fibrochromic. It matches sutures. Then we change the attention to the turbinates. Inferior turbinates are usually, in my practice, is reduced with a submucosal resection using an inferior turbinate shaver with few strokes of back and forth under the mucosa. The bony part of the inferior turbinate is reduced in size, so we can out-fracture. As you see, while the shaving is performed, we can see more of the airway and middle turbinate on this patient. This will take about a minute or two. Then, as you see, again, middle turbinate is more visible while we are reducing this in size. Now, middle turbinate is on the view. And middle turbinate will get much smaller after the swelling is reduced over the next few weeks. For the middle turbinates, as you see, it is more visible. If patient has concha bullosa, the middle turbinate shaver is different than inferior turbinate. As you see, it is more round and is used only on the one side of the concha bullosa, since concha bullosa is like an eggshell, and we don't want to remove too much of the mucosa in the nose to cause aggressive nasal dry. Then nasal stents are placed and closed. Thank you.
So after surgery, we usually put a stent for the 1 to 2 weeks based on the work we have done, humidifier, nasal irrigation, and I usually, when I take the nasal stents out, I recommend the patients to do nasal irrigation for 2 to 3 weeks for better healing. Complications are rare: bleeding, airway issues, aspiration. Anesthesia complications can happen. Very rare complications like CSF leak, pneumocephalocele has been reported. Long-term complications like septal perforation, dry nose, or empty nose syndrome has also been reported. Changing the gear to temporal trigger sites. Two nerves, they're very small, but they can be problematic. Zygomaticotemporal branch of trigeminal nerve or auriculotemporal nerve. Zygomaticotemporal is branch of V2, auriculotemporal is branch of V3. As you see here, green is the V3 and the blue is the V2 one. Zygomaticotemporal, as you know, is the sensory branch, supplies a small area in the temporal. We cut this nerve in craniofacial surgery routinely with no big issues. The nerve comes inside the orbit, then goes to the temporal side. In the orbit, it comes through the inferior orbital fissure, goes to the lateral orbital wall, passes through the zygomatic bone, and goes to the deep temporal fossa, and comes either through the muscle or between the bone and the muscle, and goes to the deep temporal fascia. As you see over here, it pierces the deep temporal fascia and goes superficially. There are multiple anatomical studies done about this nerve. It showed that the nerve passes through the deep temporal fascia around 17 millimeters laterally and 6.5 to 7 millimeters cephalically, and has multiple branches, cephalic, lateral, or right next to the main branch. So that is why endoscopic approach is my favorite technique for this one. Another study that shows the intramuscular passage that could be straight, short, or long, or tortuous inside the muscle. Anatomically, surface anatomy shows a little bit of a depression or hollowing in that area, which helps the nerve block in that area. Passing through the bone, muscle, or muscle fascia or vessels could be the trigger impact. areas. The goal is to either avulse the nerve or decompress the nerve. Study done again by Dr. Garan showed that the avulsion of the nerve is going to give you the same results as decompression. I try to do avulsion so I don't have to come back just in case, just being paranoid. And usually the way we go with the endoscopic approach, we try to go deep to the temporal fat pad, superficial temporal fat pad, as Dr. Gairam mentioned in his video. That's very important that stay under that fat pad and go from there. There's a video again going over this.
We will go through the endoscopic approach for zygomaticotemporal branch of trigeminal nerve and anatomical variations. Using two endoscopic access devices, we start dissecting over the deep temporal fascia. As you see with the obfuscator elevator, we are separating the tissue off of the deep temporal fascia. When we reach about few centimeters below the access ports, this is the area that you see some fat pads that needs to be elevated. This is the junction of the superficial layer and deep layer of the deep temporal fascia. This is very important to keep the frontal branch of the facial nerve intact and be in a right and bloodless layer. Laterally, we are in the deep temporal fascia. Medially, we are over the periosteal level. Sometimes we see accessory branches, as you see in the way of my dissection to the lateral orbital commissure. I see a small branch, which is the beauty of the endoscopic approach to see the wide area. As you see, there's a small vessel and the nerve before to the area that I expect to see the nerve. This is way higher than that 17 millimeter and 6 millimeter that we discussed. So we cauterize the vessel and avulse the nerve. Since this is not in a usual location, I'm not convinced that this is the only branch. So we continue the dissection. As you see, I just reached to the lateral orbital rim and supraorbital rim, separating that from the tissue by further dissection in the lateral orbital rim area with that measurements that we discussed prior. In prior slides, I see another branch. This is the main branch, which is small, which is expected since we had another accessory branch. So after isolation of the nerve and the hemostasis, as you see, then we can treat the nerve issue. Again, this slide is just to show the anatomy of the nerve and the variations. When I grabbed the nerve, you saw that there was another small branch behind the nerve and a smaller one, as you see when I'm pulling. So there was two branches right at the same location. So I will make sure that there's no branches left. As you see in this video, we saw a cephalic accessory branch. We saw a branch right adjacent to the nerve and the main nerve so far. Still, we need to look further.
Okay, so we're going to keep going with this. Palpebral approaches and lateral temporal Gillies type approaches also been described with this one. Auriculotemporal nerve is one of the easiest trigger points to treat and also one of the common ones. Again, it's a sensory nerve, supplies lateral scalp area. More common than initially what we thought. This nerve is involved, and we are doing them more and more. As we said, it's a V3 branch. It's part of the, it comes out of foramen ovale, has multiple roots sometimes, goes around the artery, wraps around the TMJ, and comes with more superficial layers. The triggering sites, usually it's the artery, but fascia also could be causing some pressure on the nerve. So it shows the fascia in one of these slides and also the nerve in the artery in the other one that's causing. This is a slide from Dr. Gairan's article what we usually do, have the patient to show us the pain location, as Dr. Garan mentioned, and Doppler that site. And we can see when we are opening that area, you see that the nerve and artery intertwine sometimes. Nerve could be superficial or deep to the artery or just next to it. And sometimes, and after you remove it, basically everything is gone. The nerve is over there, but the artery is removed. Sometimes we remove both of them. And this shows the roots of the auriculotemporal nerve. There was a great study I found that arteries sometimes deep to the superficial layers around the TMJ joint, the artery goes through the roots of this nerve most of the time. The sequence of the surgery is that, again, identify the tender point. We just ask the patient. Which is usually at the hairline or posterior to the hairline. Confirm it with a Doppler, explore the area, remove the artery and the nerve. This is what I usually do. When I remove the nerve, I bury it in the, clamp it and bury it in the muscle or tissue around it and excise the piece of them. Recently, after an article was published, I tried to go more proximal in the pre-auricular area and also remove a piece of nerve and artery in that location. As you see in this patient, this is the ear, and this is literally pre-auricular area. When I opened this patient, this is actually one of Dr. Ansari's patients. When I opened it, there's a huge superficial temporal artery pushed out. And as you see under that, you can see the branches of the superficial, the auriculotemporal nerve, as you see in the picture over there, that the nerves are basically transected as well. I just talked to the patient last week. It was after 2 years after surgery, and he's doing great, actually. He's pain-free from that area. I think that slide concludes my presentation. We are ready to start the questioning, and if you guys have any questions, we will start discussing those questions. Okay. I don't see any questions in the chat box. Dr. Gosain, do you have any comments, any questions from you?
Yes, great presentation from all of you. Just a few questions for each, starting with Dr. Ansari. You had spoken, I know really the elephant in the room, if we want to call it that, is how do we get patients to the proper treatment? And that's what we all are trying to understand. When I turn on the television in the evenings, I see all these ads for Botox for chronic migraines, and there's no ads for surgical deactivation. And I know a lot of it is going to be partly marketing, where the market is going to take the patient, but also where the neurologist will send the patient. Can you talk about some of the struggles we're having in trying to figure out how best to refer patients?
So that is, we can talk about that this subject for days, and still we don't go anywhere. So as you mentioned, yes, the marketing and that advertisement is a big in the headache world. And in fact, the Botox, which is basically now the AbbVie company owns it, plus some of the other migraine medication, that AbbVie sponsor all of the Headache Society meetings. So that's the main sponsor for all of those. And that's why they're going to have that strong foot in this world, and they want to basically push their drug, and either Botox or other drug that they now have available for migraine. And so that has been a struggle and will be a struggle. The best way is just webinar like this, or 2 days ago, me and Dr. Tutunchi had another webinar with the for the society called Migraine for Otolaryngologists, and we had some presentation there, also some webinar like this. So just spreading the word that people know, that will be the best way to basically so people know about this. A lot of neurologists or even a lot of plastic surgeons in the community, which I saw them, they don't know about this procedure or this surgery. So that's why, again, this kind of the educational webinars will be the best way to go.
Do you see in your headache societies, like you talked about the giants talking about peripheral versus central origin and all, do they actually debate in the headache societies about surgical deactivation versus other forms of treatment? Because that's where we need to get those debates going.
So this debate is actually done 10, 12 years ago in IHS when Dr. Gayuran and Dr. Diner did that debate in IHS, International Headache Society meeting. But that was a long time ago. At that time, a lot of neurologists was pro for central. Now, as I mentioned, the number of the neurologists who are believe on peripheral getting more and more, including the current president of International Headache Society. So yeah, I agree that might be a good time these years to basically do something like that. In fact, we are planning to do something, maybe not debate, but something at least in this regard in the next year's International Headache Society meeting, which will be in Brazil.
Great, thank you. Then question for Dr. Garan. You talked about the palpebral approach for the frontal headaches, and then you said if there's temporal involvement also, then you're more likely to go endoscopically. Do you think just looking at your results with frontal, is endoscopic versus palpebral, is one more effective than the other? The other question I had, you showed you were turning the foramens into supraoral notches when you did the open palpebral. Do you do the same when you do the endoscopic approach?
Thanks, Aaron. The foramen is something that obviously can be seen more readily if we're doing an open technique and go to the periosteum. But most surgeons do not actually touch the periosteum. So because of that, endoscopic approach may be better for them to visualize particularly the accessory branches, and also if there's a foramen. The question is, if you find a foramen, can you actually do a foramenotomy transcutaneously? Because of craniofacial training, you and I can do that. But I'm not advocating that to individuals who are not familiar with the anatomy as much, and the open technique, meaning transpalpebral approach, would be a better choice. But what I do invariably is, first of all, open the periosteum, take a look at, make sure that there's no foramen. It is just a notch, and release the fascia. But if I have any question that there's a foramen, again, I'm going to do a foramenotomy. The other possibility is to have a CAT scan preoperatively. If you're not going to, if you're reluctant, the surgeons are reluctant in opening the periosteum, then the second best choice would be, or even combined choice, would be to have a CAT scan of the perinasal sinuses that as I mentioned in my presentation, it's going to show us whether there's a foramen or not, and whether there are accessory nerves or not. And it will make our operation more successful.
Thank you. And then then I want to ask a question of Dr. Tatanchi. Ali, you had mentioned, you talked about your very elegant techniques for turbinectomy. But the soft tissues are left behind. Do you find that those retract nicely after you take the bone out? That's my first question. And then my second question for you is, many of your techniques involved actually avulsion of the nerve as opposed to just decompression. As say when Dr. Garan did the greater occipital, it was a decompression of the muscles and vascular structures. Whereas with the temporal branches, it's often an avulsion. Is there a difference in the outcomes from decompression versus avulsion, or is it specific to the nerve?
I mean, I'll answer the second question first. Usually the rule of thumb is that we cut the smaller nerves, decompress the bigger ones. Auriculotemporal nerve, majority of the time, is a small nerve. So when it's a small, we decompress like a wall stem, zygomaticotemporal. But when the nerve is big, like a greater occipital nerve, then we decompress those nerves. Supraorbital nerve, we always try to decompress them because cutting it is really cause lots of issues for the pain. In terms of the nose question, when I'm guessing that you mean middle turbinate, going to the middle turbinate. Yeah, when we are going to the middle turbinate, usually the stuff that's on our way to go there, it's either deviated septum or inferior turbinate. When we inject the inferior turbinate, it gets smaller. We shave them, out fracture them. And actually on my video, I mentioned the video, like a view before injecting and the view after injecting and doing submucous resection and out fracture, which opens the way all the way through. I try to do the septoplasty first, do the inferior turbinate, which opens the way all the way to the middle turbinate to have a better view.
Great. Thank you. If are there other questions, Ali, from the audience?
There are no questions in the chat box. Our emails, by the way, it's in the chat box if you guys want to contact us with any questions. I have a question for Dr. Ansari. And actually, we know, Hussein, that neurology community is not completely on board with the surgery, but they're turning around. Bigger centers actually in our city, they're starting to send patients routinely, the ones that are not responding to the treatment, which again, it shows that specifically younger generation leaders, they are turning around. But the one thing that was really surprising to me is that the neurology community is very, like they are okay with the nose treatment, but the ENT is against it. I wanted to see what is your take on it and why do you think that is? Because neurologists, they want to send the patients and they can't find anybody to do those surgeries for them.
Yeah, that is something that we see all the time because the ENT doctor, they don't understand the relation between, not all of them, but most of them, they don't understand the relation between migraine and possible intranasal trigger point. We know this very well. We actually examine the patient, we take the history as a headache specialist, and we know that it's one of the major trigger. And as Dr. Gayuran also in one of his article, I believe he wrote that those are the people that less likely to respond to something like Botox when they have intranasal trigger. But yes, the ENT doctor is very interestingly, they don't believe or they don't think that this exists. And
this observation,
lack of education, I think that's it.
This was really surprising, that neurologists are okay with the intranasal surgery, but ENT guys are the one that will usually turn away the patients that they say don't do the surgery. And I was really surprised in the webinar we had 2 days ago, how many ENT doctors were against headache surgery in the nose.
Yeah, but remember, even you're talking about the neurologists. No, still the old generation neurologists, they don't believe even in intranasal. They don't stand. So all of the patient that you see probably and things from this newer generation, which is more open-minded and more understanding about this relation.
Dr. Gayran, do you have any final comments? We have 2 minutes.
Yeah, actually, getting back to your question, Ali, not only that, even when they do concha bullosa, they actually remove the lateral portion of the concha bullosa and leave the medial portion that is the contact point and causes more headaches, or is more likely to cause headaches. So it is amazing. But I just it's all about education. I think unfortunately their training doesn't include anything about the migraine surgery. Now many of our residents are exposed, and hopefully the education will be disseminated, information will be disseminated more and more as we do these seminars and have symposia. And those of you who are interested, actually, we do have yearly symposium before the AAPS meeting, which is a whole day symposium, and we cover from A to Z. And during the AAPS meeting, we have actually an advanced course for migraine now that has been going on for a long time. The symposium has been around. We started it from Cleveland in 2006. Now 18 years that this symposium has been going on, and we have been educating a lot of people about migraine surgery. What I want to say that of all the things that I do, this is the most gratifying, most fulfilling for me over the last 24 years that I've been doing this. Patient after patient telling us, not just me, Dr. Tutunchi and others that have embraced this technique, that their lives have changed. And then when we do rhinoplasty or other things, we really don't change their patients' lives as drastically as we do. Obviously, craniofacial surgery is very different. If obviously you're interested, you're on the call this late at night, and we want you to contact the society, become involved, and you're going to be enjoying it tremendously.
Thank you very much, Dr. Gairan. Thanks, Dr. Ansari, for your presentations. And we'll give the final closing remarks to Dr. Gosain. And again, Dr. Gosain, thank you very much for the opportunity.
Well, this is the type of education we need. I was just at the American College of Surgeons, and we had a medical student forum, and the medical students asked, "What is plastic surgery?" And I said, "Plastic surgery is applied anatomy." And you have demonstrated that in your beautiful videos and slides today. That really taking applied anatomy, applying it to a problem, and then watching the outcomes over so many years is really plastic surgery. And that was not plastic surgery 20 years ago, but if we go in as applied anatomists, we can do so much. So thank you all for doing that.
Thank you. Thank you very much, and have a good night, everybody.
Good night.
Thank you. Good night.